Growing up, I knew my parents were there for me. We celebrated family events. They were there for me when I was sick or needed help. As me and my sister grew up, we knew we could count on our parents. We were so proud to be their children. Today, we are there for our parents, to share in the celebration of their grandchildren or to be there when they are ill or need assistance. They can count on us. And now our parents look to us to take care of them. Hello, I'm Michael Wilsker, and I'll be host of Always There. Thank you for joining us. Just for a little background, I'm an owner of an elder care agency called Always Best Care Senior Services. The company provides in-home non-medical care for seniors, and we also provide free placement for those looking to live in an assisted living facility. Before we get started, I just want to let you know that the show now is on 12 different towns' cable stations. Amongst them are Northborough, Southborough, Shrewsbury, Milford. We just are going now on Hopedale and Uxbridge, and Framingham, Natick, Needham. So if you have any friends that live in those areas and want to tune in on us, please have them look at their schedule. Today we're going to be talking about skilled nursing facilities, especially the short-term rehab. And today I have as my guest Lisa Kubiak. Lisa is the executive director of Mary Ann Morse, which is a skilled nursing facility and also a short-term rehab center. Yes. Lisa, welcome.
Hi.
Thank you for coming.
You're welcome.
Lisa, just give us a little bit of your background. How did you get into being an executive director? How long have you been doing this?
Well, I started with I got my degree from Ohio State University as I'm a registered health information administrator. So when my kids were young, I wanted to be able to stay home with my kids. So being a registered health information administrator, I dealt with documentation and things like that for medical records and such. So a friend of mine was an occupational therapist, and she worked in skilled nursing facilities, and they were looking for a consultant. So she called me to come in. So I actually started in skilled nursing facilities about 20 years ago when my kids were little, and it gave me a chance to stay home with my kids, but to also be working. So through doing the consulting in skilled nursing facilities, as my kids got older, I decided I wanted to get my nursing home administrator's license because I really liked working in that field. So as 12 years ago, I got my licensed nursing home administrator's license, and then I started working as an administrator in skilled nursing facilities.
Well, it sounds like you really like what you're doing, and that's, you know, we're all here to make a living, but we're also trying to do something that makes us feel good and give something back.
Absolutely, I love it. I wouldn't want to be doing anything else.
And how long have you been with Mary Ann Morse?
I've been with Mary Ann Morse for 6 years.
6 years.
Yes.
And so we're going to be talking about the rehab, and so if you want to just give a general definition to the viewers about what the short-term rehab is all about.
Well, most skilled nursing facilities have different levels of care, and they'll have the long-term care, which is traditional long-term care where people come to stay. But then what's been happening over the past few years is there's become more of a need for short-term rehab. So patients would come in and they would have inpatient rehab at the skilled nursing facility, and they stay, you know, it's basically what the need is. If it's a total knee replacement, they may be there 5 to 7 days. Total hip, maybe, you know, a couple of weeks. From strokes, that may be there a little bit longer. But the goal of the short-term rehab unit is really to get people in a position where they can go back home safely and lead a productive life out in the community.
What about age? Do you have to be a certain age in order to be in a short-term rehab? Can you be 16, have a broken leg, and go there for rehab, or that's usually other places?
Usually for a 16-year-old, it would be someplace else. Most of the skilled nursing facilities will take people, you know, usually in your 50s or higher. It's mainly for senior care, but there are facilities out there that would take younger people. So it really is dependent on the facility and what their goals are.
Now, do you work with certain hospitals, or how do the patients come to a rehab?
There are a few different ways, but mainly through the hospitals. A patient might go to a hospital and they have an acute episode, potentially, or they might go in for an elective surgery. There's a case manager at the hospital that will, if they need the inpatient rehab services before they go home, there's a case manager, a social worker team at the hospital, and they'll talk with the patients, and then they'll, you know, they know who does what in the community. They know which which facility might be better at cardiac rehab versus which facility might be better at orthopedic rehab. So they'll give the resident some choices of where they want to go, or the resident can choose where they want to go if they've already done their research. So that's how the screens come to the nursing facility, to the rehab section. So the patients, it starts in the hospital, or it starts at home if you're an elective and you've already done your research. But through the hospital to case management, through the admission team at any skilled nursing facility that you're going to go to for rehab.
And what about, can you just go a little bit into more the team concept of taking care of the resident? Is it called a resident? How do you, what is they?
Well,
what are they called?
typically, you can call them call patients different things. If it's a short-term rehab, you call them a patient because they're a patient, they're going to go home. If it's someone that's living in the long-term section, they're a resident because they live there and it's their home. So when you come into the skilled nursing part of the when you come into the rehab section of the skilled nursing facility, you're going to have a team that work with you. There's a nurse, there's nurses in the facility, there's certified nursing assistants, there's the rehab team which does physical therapy, occupational therapy, and speech therapy. Some facilities will have respiratory therapy as well. Then you have social work team, you have an activities, and you have dietary. So everybody works together from the time you come into the facility to the time you leave. And the goal from the time you come into the facility is to get you ready for discharge. So everybody works together from every discipline because someone coming in might have special diet needs. So that's why the dietitian is there, to make sure that their diet stays
that they're taken care of nutritionally.
Yes.
Right.
So if they're a diabetic, they're making sure that their food intake is what is supposed to be appropriate so it doesn't cause any medical issues that would interfere with their treatment while they're there for rehab, to make sure that they have the smooth stay while they're in to be able to get out and get back into the community.
You know, before we went on, we were talking about the Red Sox. And the Red Sox have a manager. Is there a manager of these teams, or they just all of them get together and decide, have a consensus of what is going to be done for each particular patient?
Well, every department has a manager, but it's really who's working with that patient will be part of the team. So, for example, in rehab, there's a rehab manager, but the physical therapist that works with that person, that patient, will be the one that works with the team on the discharge planning and the patient care while they're in the facility. So the
social, through my experience, I always thought that there was a social worker that was pretty much the one who was managing it because she puts the pieces together. So respond to that, then also tell me what the difference is between a social worker and a case manager.
Well, the social worker takes the lead in the discharge planning because the social worker is the one that's going to make sure servicers are set up when they're leaving, to make sure that if they need to have home health agency and when they go home, that they're going to make sure that they have the discharge plan in place. They'll be in charge of making sure they have the family meeting in place. So not only the patient but the family are all aware of what's going to happen along the course. So the social workers will take the lead in that role, but everybody else plays a part in letting them know what has to happen. Rehab will let them know these are the things that we need to work on while you're here. Your balance, your activities of daily living, maybe cooking requirements. So they'll let the family know and the patient and the whole team, this is what we need to work on. Nursing will be a part and let them know that, all right, we have pain issues maybe, so this is the pain management that we're going to do. Or if there's any wound care, because maybe they're in the hospital and got a little wound on their foot or something. So nursing will take care of that piece of it and let the patient and the family know this is what's going to happen. But they all work together so that it's truly an interdisciplinary approach to patient care.
So what is your role as the executive director? Or what's the role of executive directors in skilled nursing?
My role is to support my team, basically. I give support to the team. I make sure they have all the resources they need to provide good quality care. And I just make sure that they're all working together as a team. It's just really supporting everybody.
And what's the physician's role?
The physician is to take care of the patient while they're in the facility. So any person that comes in to any skilled facility has to have a covering physician. Usually facilities have physicians that want to be there and cover, or you can bring in your own from the outside if they want to cover your stay there. But they'll see the patient when they come in, they'll do a history and physical, and then they'll monitor the patient's care for the entire length of their stay. So if there's any medication changes that need to be done or anything that happens, the physician is always there. And depending on the type of facility you go to, the physician has nurse practitioners, so you'll get a lot of coverage. You'll have
Right.
typically nurse practitioners and physicians there quite often, so you get good medical coverage.
And what is a nurse practitioner?
A nurse practitioner he or she would work in conjunction with the physician. It's an extension of the physician. They don't have to have the MD, but they go to school a little bit longer than maybe an RN. So they can actually.
So they work for the
They work
rehab?
for the physician.
They work for the physician.
They work for the
Okay.
physician.
Is that
They're-
common to have a
Yes.
nursing? It is.
It's very common
Is that something that's
because
developed over the last number of years, or is
it's
something
probably
that's
gotten
been-
more common over
more
the
common?
last several years,
Uh-huh.
but it's just an extension because the physician might not always be able to be there. But the nurse practitioner can be there and they can do orders and they'll consult with the physician if they need to make any changes with treatment. But it just gives you that extra medical coverage. You know, some facilities will have a nurse practitioner that works for the facility, and some will have it through the physician. So, I mean, you're going to find, if you go to different places, different scenarios.
Now, when the social worker meets with the family to prepare to come up with a discharge plan, I have to assume, based on my experience in the industry, is that the alternatives are going home with or without in-home care, going into an assisted living with or without with their own private care, or going into a skilled nursing facility. Is that pretty much what the options are, or am I missing something?
Sometimes they choose to go live with family members, but that's similar to going home
Right.
with care. Honestly, I'm probably not the expert on answering that question.
Okay,
I'm trying to think of alternatives or
I'm trying to
restroom,
think
but
of another thing, but I don't think
yeah,
there is.
no, mostly
I don't think there is.
it's mostly to go home or to go to an assisted living. Even if they go home and some residents live in senior housing, so they might have a little bit more help in that. You
Right.
know, if they
Right.
they have Lifeline in the facility in the
Right.
apartments.
Right.
So yeah, but it's basically going home to wherever your home situation was, to an assisted living, or there's
Right.
independent living actually.
Right, I know that.
Which is
and then you
separate
have to
from
have
home.
an assisted, you have an in-home care
Right.
private person that does that. Now I've learned, my chain of thought has, has gone out. In the facility itself, what's the interaction between those in the rehab and those in the skilled nursing center, the ones who are there long term? Is there an interaction? Do they have separate, you know, are they part in the same bed system, or are they separate?
Well, I know where in our facility we have a separate short-term rehab unit, and then we have a separate long-term and memory care. And I know in other facilities, it's a lot of places try to have a separate short-term rehab unit, but there are facilities that they would be integrated to some extent. But really, the goal is to try to keep short-term rehab its own separate entity within the facility. So for the long-term care and the memory care residents in the long-term care portion of the facility, they would still have access to rehab. They would still have access to the same type of things, but they don't get the intense rehab like you would in short-term rehab.
Right.
If someone in a long-term unit has a decline, rehab might be able to pick them up on services just to be able to get them back to their regular level of functioning.
Right.
So they'd still be involved, but not to the extent. Like when you're on the short-term rehab unit, the physical therapy, occupational therapy, speech therapy, or respiratory, if you have that in your building, would be much more involved, and you could get more hours per day. And that your goal is to be there for therapy and for nursing care. Well, not that the goal of the long term, you're still getting the nursing
Right.
care, and you're
Still
still
getting nursing care.
yes.
So when you're in the short term, what's the typical stay for someone in the short term, in the short term rehab?
The typical length of stay is usually less than 21 days. If you're a joint replacement, like a knee, you might be there 5 to 7 days. If you're a hip replacement, you might be there 14 to 21 days. But like for Medicare, the average length of stay is about 17 days.
17
and if you're a
days.
managed care, which would be like a Tufts of Blue Cross or such, would be probably about 14 days. But it depends on the diagnosis. Like if you have a stroke, you're probably going to have a longer length of stay just because there's a longer process to get back to close to a baseline, if not at your baseline from when you before you had the stroke.
So how long, if Medicare allows it for 17 days, what happens after that if they have to stay longer? Does Medicare then extend the coverage?
If they still meet the need of Medicare coverage, the need of skilled services, which would be a skilled nursing service or a skilled rehab service, then Medicare would continue the coverage. You can have up to 100 days
100 days, right.
of coverage, but it really depends on where you're at medically. So if you require the services, you can stay on. But if you get to a point where you're no longer needing skilled nursing services or skilled rehab services, that's when that would be the end of your Medicare coverage.
Okay, so I'm going to ask you this. Now, there's a couple of different rehabs that don't have beds, like I guess Spalding and Whittier. How does that differ from a short-term care rehab that's at Mary M. Morris and other long-term care facilities?
Spalding and Whittier are acute rehab facilities. So they're probably, you have the hospital, which is an acute facility, you have the skilled nursing facility. Whittier and Spalding, as being an acute rehab, would probably fall somewhere in the middle. So us being a skilled nursing facility, we can do up to 2 hours of rehab a day, where Spalding and Whittier being an acute rehab, they can do more hours of rehab a day.
Now, they have outpatient and inpatient. Both of those are acute, don't they usually have in and out, or is it usually just outpatient?
I know they both have inpatient as well. I know Whittier has inpatient and Spalding has inpatient, I believe, and then they have the outpatient as well. They can do both, but it would be both. Yeah.
Now, we were talking about before about how to determine which rehab center to go to after you're being discharged from the hospital. Who gets involved in that? And are assessments done? The range that all comes from the social worker in the hospital, sits down with the family and goes over their options as to what rehab they want to go to. And then, so what's the process in that situation for the rehab center?
So what would happen is the discharge planners, case managers from the hospital would send out a screen to the skilled nursing facilities.
Send out a what?
A screen, a referral.
A screen. I thought you said scream.
No.
Get out of here. She can't be here anymore.
It's a referral screen, but no. Okay. So anyway, once we get the referral, then we have screeners in our facility, which are nurses. And I know typically it's a nurse that does the screen for any skilled nursing facility. It doesn't necessarily have to be a nurse, but you have someone that can look at the referral and make a decision if that person, if your facility is capable of taking care of that person and their needs, and if you have an opening, and so on and so forth. And so then our people, our admissions department, or any skilled nursing facility admission department would get back to the hospital saying they accept this person, or they can't accept because they may not have a male bed for something like that.
And what do you find? Is there mostly women who go into rehab, or as opposed to males?
No, I think for short-term rehab, there's probably an equal number of men and women, but your typical skilled nursing facility has generally more women in it.
And why is that? Because women are living longer, or they're the tendency to get into accidents more than men do?
No, they don't get into more accidents than men. I think it's because women are living longer.
And again, so let's just go back to are you just the executive director of the short-term care, or you're also the executive director of the entire facility?
I'm the executive director of the entire facility.
So what exactly is the typical stay at a skilled nursing facility, at the skilled nursing?
Well, the rehab.
I'm just going to the nursing facility now.
So the long term.
Right. What is the typical stay for that?
It's probably, I don't actually have those numbers with me. I would say between 1 and 2 years.
1 or 2 years?
Yeah. It used to be longer years ago, but that's getting shorter because there's so many resources out in the community now that people are getting to stay home longer, or getting to go to assisted livings before they come into the long-term care. So when they come to us, they're a little bit more fragile.
Let's go into meals. Now, people who are in hospitals, the meals are terrible. Nobody, that's typical. It's just to get them out of the hospital. I guess they give them lousy meals. In your facility, are there separate dining room for those in the rehab and those in the long term? And the chef serve food for both sides?
Well, the kitchen would serve the same food throughout the facility, but every place is a little bit different. But usually most facilities have a main dining room that residents can go to, or patients. But typically on a short-term rehab unit, there is a separate dining room. And a lot of short-term rehab patients will eat in their room as well, just because they're there for rehab. They're very focused on what they want to do. So they want to get in, they want to do their treatment, they want to have their nursing care, and they want to get home. So, there's options to eat in your room, there's options to eat in the main dining room, there's always options on the unit in a little common area, and that's throughout the entire facility. And most places have the same type of setup.
And let's talk about a little about the physical therapy. Physical therapy, you have the physical therapist, and do they have like their own area where they do the physical therapy? And it has to be monitored, I'm assuming, once therapy starts. Is that correct?
Right. Well, the therapist will always stay with the patient,
Right.
yeah. So it's always monitored, and there's usually a rehab gym, and there's a physical therapy gym that has all the equipment. So you'd have the bikes or the treadmills and so on and so forth, the mat. So there'd be a rehab gym, but they also do work in their room, like with getting in and out of bed or doing things, because when you go home, you're going to have to be able to get yourself in and out of bed and so forth. And then they can do walking in the halls, because a lot of facilities, if you're just ambulating and getting someone walking, the halls are a good place to do it, because you're not in just a rehab room where you might just have to walk in a circle.
And what type of activities do they have for the patients?
All kinds of activities. There's your typical bingo, and I know everybody says bingo, but they really love bingo. But we have a lot of, we have chair exercises where they do like chair yoga, chair, things like that. We have entertainment. Most facilities will do entertainment, at least once a week or so on and so forth. But there's entertainment. Patients can go out of the facilities. They can go, I know, speaking for Mary Ann Morris, we do out trips to restaurants. And I know other places, because I've been to other places, they'll do the same type of thing. So there's a whole variety.
Sounds like fun. I want to go into rehab right now.
It's not the same as it used to be years ago. Now you want to look at the quality of life, whether it's for long-term patients or for the short-term rehab patients. It's the quality of life when they come in. It's still making sure that their stay is everything from trying to do the best food you can, trying to have activities. So when they're in between therapy, it's not just we're sitting here watching TV the whole day. Have everybody get involved in something. So it's a whole, that's why when you say interdisciplinary, that's why dietary activities, everybody's involved, because it's not just 2 hours of therapy, maybe your nursing care, and then what do I do the rest of the time?
Right. Now, what about with doctor's appointments? Does the physicians who are monitoring and taking care of the patient, do they come to the facility to be with the patient, or do they have the patient come to them?
Well, the primary care physician for their facility stay would come into the facility to see them. And really it would depend on who the consulting physician is. Like if it was a patient that had a joint replacement, they would go out more than likely to their orthopedic for the follow-up appointment, and then just come back to the facility. So it really depends on the contracts that facilities have with their physicians and who's doing the consulting.
And how is that arranged? Do they have an ambulance or a van that picks them up and then takes them to
the facilities usually arrange for the transportation, and it's either if they have to go in an ambulance, they would set up an ambulance, or if people can go in a chair car. Sometimes, if they're very capable, a family can always take them as well.
Can you think of any situation that you've been involved with that's very out of the ordinary there? That a patient came in there and had this type of condition that was never, that was more of a challenge than other conditions that people come in?
I can't,
just off the top
of my head, no. But
no?
I think you're seeing a lot more people coming to a skilled nursing facility for rehab that is more medically complex than you may have years ago, because the focus seems to be changing. They're in the hospital if they're acute need, then they need to, discharge them from the hospital, so they come to us and they're more medically complex. And now, people that might have been higher functioning might be able to go home now, where, a few years ago they were coming to rehab.
Right.
So it's all evolving, and things change frequently.
So when the patient gets discharged, my understanding is that they usually have a physical therapist, an occupational therapist, a speech therapist if necessary, and a visiting nurse. Mm-hmm. Now, do you provide the therapists, or are those independent therapists once they come out? And do you, if that's the case, do you recommend the therapists that they should use when they do go home?
That we don't provide home care once they leave the facility, but that would all be set up through the social workers on discharge. And if they needed therapy, physical therapy, occupational therapy, a lot of it's done through the home health agency that they go with. Most home health agencies have a rehab staff and a nursing staff.
Now, is that also up to their election? They can decide which home health agency to go to?
They can choose who they would like. Everything's patient choice. So that's a key thing. That's a good point. Even coming to a skilled nursing facility, patients have choice from when they're in the hospital. If the case manager is giving them options, but they know they want to go to this other place and it wasn't an option given to them, they need to say that this is where I want to go. It's advocate for yourself as a patient, and it's all about your choice, what you want to do. So the same thing when they're being discharged from a skilled nursing facility to go home. If they've already had a relationship with a home health agency, then typically they'll stay with that agency because they already know them and they're comfortable. But if they haven't, then we would give them recommendations for what's in their area where they live. What's some agencies that would go out there, and then they would be able to look into it and choose what they want. But a lot, people will ask for recommendations, and if they don't already have an affiliation with someone.
Right. So I guess the social worker is the intermediary and is the one who makes them feel a lot more comfortable about what their choices are. Because I'm assuming a lot of people that go into rehab, it's, gee, Dad just tripped and fell. He went to the hospital, and now he's got to get into a rehab. Okay, what do we do now? We knew about the hospital part. That's pretty easy. But now, what do we do? What's the next step? Because it's a crisis situation.
Right.
Who do we turn to? Who do we talk to? So
and
that's got to be a lot of information that's just being thrown on them in such a short period of time.
And that's where the case managers at the hospital and social workers can help them try to sort it out.
Right.
But unfortunately, people have incidents that happen. So, I mean, if you want to get ahead of the game, then you just kind of know what's out there. Like, do some research, know what's out there. And then if something does happen, you already have an idea of, I already know what this place can do. I know what this place can do. So that's where I want to go. So that's what when I end up in the hospital, if, God forbid, something happens, I already have a plan in place.
Right.
And my family knows my plan. And then I can make sure the case managers at the hospital know my plan. And it's smoother that way, because then you're not panicking about, oh my God, where am I going to go?
Right. Well, I think you've given us a lot of information,
I hope
and I think you made people feel a little bit more comfortable about what the rehab centers do as opposed to going into a skilled nursing facility, that they're so different from one another. And if anybody has any more questions about any of the things that we've talked about today, you can send an email to alwaysthere@westborotv.org. I want to thank Lisa for appearing on the show today.
You're welcome.
And hope you all have a wonderful day. And I think this show is going to be broadcast in November, so have a happy and healthy Thanksgiving. Thank you.